everything. And Gina and Dr. Spurlock, y'all have the floor.
Good, thank you. All right. So can you all see the screen? Yes? Okay.
Looks great.
Well, thank you all and welcome. But Ellen, thank you. You know, whenever I'm invited to speak with Dr. Spurlock, if you've ever had imposter syndrome where you feel like, oh, that's always that feeling when you hear those credentials and you know that your co-member, your team member has done so much, I feel very honored. But I want to tell you that I thank you and I welcome all of you. This is a topic that has been of interest to many people, not just those of us in the profession, but especially those family members and caregivers and persons with early dementia that are concerned about the topic of paranoia, hallucinations, and delusions. And these are symptoms that are usually found in persons with dementia, especially with Lewy body disease and Parkinson's, and they're very difficult to address. So we know that it's as uncomfortable it is for us to see people with this, it's very uncomfortable for the caregivers and the persons living with this. So what we hope to do today is to give you an overview. We're going to look at some of the definitions because people use the definitions interchangeably and sometimes incorrectly, but that's okay. We're going to talk about those definitions. We're going to talk about, how some of these, how it comes about and what are some of the treatments. And I'll just go ahead now and give you the goals. Before I go any further, I want to tell you all that we recognize that you all are really the experts. Those of you living and caring for persons with dementia, by now, many of you have learned a lot of this, and through your own work and living with them, you have found a lot of very good treatments and things that work for you and practices. So at the end, we'll have question and answer, and please feel free to share and feel free to share in the chat. We may not be able to address the chat because we're going to leave the questions and answers until the very end. But I want you to know that we honor what you have learned as well, and we'd be happy to hear from you while we're doing this. So let's just go ahead and talk about, this is what we're going to be discussing. What is psychosis? What are hallucinations? What are delusions? What are possible conditions causing psychosis? What are the treatment options? And how best to respond to the person hallucinating and experiencing delusions. At the very end, we'll do a short vignette, give everybody a chance, kind of a feel to see, what doesn't work, what's not a good way, and what's a better way. So let's go ahead and start with psychosis, because we throw that word around, and unfortunately, it comes with a very hurtful, painful stigma. And clinically, what we need to know about psychosis, it's used to describe a condition that affects the mind when there's been a loss of contact with reality. During a period of psychosis, a person's thoughts and perceptions are disturbed, and the individual might have difficulty understanding what is real and what is not. And some of these symptoms of psychosis are hallucinations. So a hallucination is something that it happens, well, number one, psychosis happens about 10% of persons with Alzheimer's disease. And hallucination is something that's a perception of something that comes on without stimuli sometimes. People have hallucinations in any sensory modality that can be auditory, visual, tactile, olfactory. Some of a visual hallucination might be when a person sees things, or it might be a distortion. They might see an animal, a small child, they might see their mother or children walking around in the room. And that's an auditory, that's a visual hallucination. An auditory hallucination is when they hear things. They might hear voices, they might hear somebody talking to them, they might hear somebody talking in another room. This auditory. And then tactile is the feeling, is the touching. Tactile means that somebody might have a strange or unexplained feeling that somebody's maybe touching them on the shoulder, that things are crawling on them. Tactile. And then olfactory. Olfactory means that they're having a hallucination, that they're smelling things. It might be pleasant, it might be unpleasant, but it might be a constant smell. So that's what hallucinations are. Delusions are different. They're a fixed or a false perception or a belief that's not in keeping with reality. When we talk about a fixed delusion, you might hear somebody in the psychiatric field talk about fixed delusion, and that usually refers to the strength of the belief. It's strong. They cannot be persuaded differently. No argument is going to make them change their mind. So when we talk about delusions, one of the things that we leave out that we do not consider delusions as when somebody is having a thought or perception that's a result of their own cultural, their religious or cultural norm. There are some religions and some cultures that we might consider as delusional that we don't believe in. But if that's their religious or cultural norm, we accept that and we honor that as their reality, and that we don't try to fix that. We don't try to treat that. That belongs to them, and we honor that. So there are many different other types. I want to talk about what we call as the misidentification, delusional misidentification syndromes. So these are misperceptions of external stimuli, and they're usually associated with the belief or an elaboration that's held with a really strong delusional intensity. And these are often reflective of somebody having a brain disease and most affected by the right hemisphere. I'm going to go through these, and you might recognize some, and you might not. Some of the like the TV sign we'll talk about in a second is not as common. But one of the more frequent common delusional misidentification syndromes is Capgras syndrome. And this is named by a French psychiatrist, and he described this disorder way back in 1923. And it was a case of a client he had who talked about doubles in her life, and somebody that had taken up the place of her husband or other people she knew. So about 15% of persons with Alzheimer's disease will experience Capgras syndrome. What it does is it causes someone to believe that someone else, maybe a loved one, has been replaced by an imposter who is identical. So you can imagine that this is a frightening delusion, can be strong. One of the things that we tell people if this is happening to somebody is that it might be helpful when you walk into the room with somebody that has a tendency for a Capgras syndrome is to walk into it, identify yourself. You walk in, hello, it's me, Gina. And those of you if you have had some training with Teepa Snow, you'll know this is one of the first things that she teaches us is to, when you walk in, they may not remember us, and it's always helpful so that they don't feel like they have to ask who we are, that we identify ourselves. So that's Capgras syndrome. And another one is the phantom boarder. And you might have a loved one, or you may have an experience with somebody who's had the phantom boarder syndrome. And this syndrome is that someone else who's uninvited is living in their home or has moved into their home. And sometimes the phantom is somebody that's not threatening. It's okay. They're somebody that's moved in. But there can be instances when it's somebody that they are worried about or scared about. I will share with you that some of the most recent research that's done about these syndromes, they're finding that the more frequently that the person was on lockdown, isolated, these syndromes went up. It was isolation, and it created a situation where they had more a delusional identification syndrome. So the phantom boarder is somebody who's uninvited, living in the house, and it can be somebody that is, pretty benign, it doesn't bother them, or it can be somebody that is scary and they don't want there. In this case, it's always mindful, it's always important to remember that safety first. If somebody becomes angry, you want to make sure that they're not going to do something to try to hurt this phantom boarder or the Capgras person. So we'll talk about that a bit later when we talk about the environment. And then the mirror sign is when somebody doesn't recognize themselves in the mirror. They believe that they are much younger. And when they look in the mirror and they say, who is that person? That's not me, because they have a sense, we call this time shifting. They have a sense because of the time shifting that they are much younger, that this person in the mirror could not possibly be me. And that can be disturbing to them. And then I want to talk about the TV sign. The TV sign and the delusional misidentification syndrome is one when the person, when they're watching TV, they believe that that observed television show, those events are happening in real time, and that this is happening in their reality. So that can be scary too when you consider the things that are on TV right now that are negative, that are violent, that are scary. And so the TV sign might be something that is very concerning to them. Fortunately, this is one of the signs, this is of the syndromes, this is one that is least common. So this is my introduction, and from here, Dr. Spurlock will take over and talk more in depth about what are some of the causes. I'm going to stop share.
Dr. Spurlock, I think you're still muted. Let's see. There you go. That should be it.
Okay, let me get back to my screen. Allowing me to. Okay, one moment. I'm having a little technical difficulty here. See what is that from? Okay, can you guys see it now? Okay, great. Okay, so in talking about these behavioral and psychological symptoms of dementia, as I mentioned, they're fairly common in persons who have dementia. And some of these symptoms, I'm sure that if you have if you're a family caregiver of a person with a dementia, or perhaps you are a professional caregiver as well, that you have interfaced with these symptoms, because they can occur, of course, in community dwelling persons with dementia, in long-term care settings, in acute care facilities, you know, wherever we care for those individuals. So one of the common symptoms is called aggression. Now, aggression is mainly more or less where another individual, so to speak, is the target more or less of the behavior. And so these terms of levels and intensity of aggression can become, you know, quite severe. And then depending also if the person is experiencing an hallucination or a delusion. Then, of course, individuals can also have agitation. Agitation oftentimes is a situation that's occurring, you know, within the individual. It may be due to some type of internal cause, and we'll talk about that later. It could be an environmental type of trigger, but oftentimes a person who is agitated can also become, you know, combative, and that can be threatening to the safety of other individuals in the environment, as well as the individual, him or herself. And then also restlessness that can vary in terms of levels of severity. There are also symptoms that we sometimes call it screaming, but maybe increased, you know, vocalizations. It could be moaning as well. Individuals can experience pacing, and repetitive motor activity. And we always, of course, have to look for underlying causes, because once we can identify possibly what that cause is, and we can eliminate or sometimes significantly reduce the behavior. Also sleep disturbance. The sleep disturbances may be more common, more or less in persons with, Lewy body dementia, but can occur in any type of dementia, just a change in the sleep-wake cycle. And then, of course, wandering. Many individuals, a large percent who have a form of dementia, will also experience wandering somewhere along the disease trajectory, and shadowing. And that's more or less in terms of following the movements of another individual in the environment. And then, of course, individuals can also experience too what we refer to sometimes as neuropsychiatric symptoms of dementia, and that can include anxiety in various levels of severity, depression, oftentimes experienced in the earliest stages of the disease process. And then, of course, what Gina has talked about, and that's psychosis, which mainly consists of the hallucinations and the delusions. So let's take a little closer look at these symptoms of BPSD. So these are referred to as a non-cognitive symptoms. So it's not we aren't really talking about memory loss, reasoning, cognitive functioning. So we know that they're multifactorial etiology, which means that the underlying root cause of these symptoms can vary widely. And then, of course, we tend to think about the language from the observer's perspective. And this is where we have to be careful in our roles as family caregivers and professional caregivers as well, because we tend to label even the individual, not only their behavior, but the individual sometimes as being, difficult, they're very disturbing, problematic, inappropriate, challenging. But this is where we have to separate the behavior more or less from the individual, and to realize that this is all a part of the disease process. So we know, of course, that symptoms are usually highly individualized, and what that means is that they will occur at different points along the disease trajectory in different individuals. So they don't always present at the same time. They can present in varying levels of intensity and severity, although they are said to be more common in terms of their occurrence in the mid, moderate, or severe stages of the disease process. So I always like to just take a brief look at core principles, more or less, in terms of when we look at persons with these behavioral disturbances. So first of all, we need to recognize that in persons who experience, who have a dementia, is that these behaviors are a form of communication, because they may have lost the ability to be able to communicate verbally. So that will be their way of communicating to us. Look, something is wrong. I need something. They may not be able to tell us that they have a really bad toothache, or they're really, in pain. So the behavior will more or less communicate that. And then, of course, it can be a result of an unmet need. So when I mention an unmet need, that could be in terms of thirst, it could be hunger, it could be, extreme temperatures, in the environment. So they aren't able to communicate that unmet need to us. And it's also important to, as I mentioned, to be able to identify the root cause of behavior. Because if we know that all behaviors are meaningful, then we're going to always try to find that root cause of the behavior, because in doing that, more or less, that we can ease some significant distress, more or less, from that individual. And then, of course, we can focus on reducing, eliminating, or modifying the contributing environments. And oftentimes the environment may play a contributing role in that. And once we identify what that is, then we can increase the quality of life for that person. Also, the symptoms are often multidimensional, or as I mentioned the word, multifactorial. So they can result from one or multiple causes. So we should always know that confusion, even in a person who has a dementia, is that should always be investigated, especially when a person who has been previously alert and responsive, suddenly becomes, confused. And then also, as I mentioned, even in the presence of a disease process, if a person has been diagnosed with a dementia, with Alzheimer's disease, and then you notice that there's a sudden change, a worsening of those symptoms, that they should always be investigated. And so when I say investigated, then I'm referring to in terms of a medical, workup or examination. So now these are some examples, more or less, of some conditions that can cause even the psychotic symptoms that Gina talked about earlier, the hallucinations especially. It can be from cerebral vascular disease in individuals who have had, strokes, in the past. It could be due to some central nervous system trauma, even to, prior head injuries. Could be from fluid or electrolyte imbalances, imbalances, especially in, sodium, potassium, hepatic or liver disease. Individuals who have been diagnosed with hypo or hyperthyroidism, that can also result in some psychotic symptoms if left untreated. Neoplasms, various forms of cancer, even from metabolic conditions such as hypoxia or hypoglycemia, or low blood sugar, and also a condition we refer to as normal pressure hydrocephalus, when there's a buildup of fluid, in the brain. Also from a vitamin deficiency, oftentimes we don't think of vitamin deficiencies such as B12 and Huntington's disease. So you can see there are a wide range of medical conditions and disorders that can result in psychotic symptoms too. But this is one that frequently comes to mind when we talk about a sudden change in a person's condition, from their previous level of functioning. You're probably thinking in terms of, and you may have seen this manifest, a urinary tract infection. And in fact, these types of infections are really seen as the great emergency room imposter, because an older adult may present in the emergency room late at night, and that person is confused, disoriented, has become, combative. And generally what they're going to do is, of course, look for underlying medical causes, and generally they'll screen for a urinary tract infection. But you may even hear family members to say is that, their family members may all of a sudden say things like, well, mom is starting to, sleep all day. I noticed that her behavior has changed drastically. She's started screaming and undressing in the public. I noticed that, she's suddenly declined, that she seems really worse now. I don't know, what happened. My dad seems more confused. So we have to also realize that older adults may have an atypical response to an illness. So whereas a younger person with a urinary tract infection may experience an elevated temperature or fever, they may, complain of urinary frequency and burning. So these may not be symptoms at all in an older adult. And even if the older adult had those symptoms, depending on the level of dementia, they may not be able to express that to you. So then, psychotic symptoms of an acute onset can also be the result of a delirium. And so that delirium can be secondary to a medical condition. Some of the ones that I've already talked about could be drug misuse, and it could even be drug-induced psychosis. So let's also look at some maybe contributing factors, more or less, for an increase in psychosis among older adults or the elderly population. So there might be some age-related deterioration of the frontal and temporal, cortices of the brain, and especially, of course, in certain, forms of dementia, where the damage to those particular areas of the brain will also what result in some of the more prominent symptoms that we see, like with the temporal lobe, the frontal lobe, and sensory processing, of course, the temporal with, personality changes that can occur. Then, of course, physical illnesses. I've already mentioned several, not all, physical illnesses that can result really in a psychotic features for the older adult. And then social isolation. I know Gina mentioned about the social isolation or, sensory deprivation. Especially more prominent following the, COVID, 19. Of course, sensory deficits in vision and hearing. And so that's why we want to always be certain and to assure that when the older individual is depending on those sensory aids per se, that we try to make sure that they're always wearing them, such as the eyeglasses and the hearing aids. And then, of course, we know that there are some age-related, what I refer to as pharmacokinetic and pharmacodynamic changes that can occur. And those are just big words to say more or less that pharmacokinetic changes in terms of, what the body actually does to the drug, and then the pharmacodynamic, what the drug actually does to the body. So we know just the normal changes that occur with aging can, significantly impact like the absorption and distribution, metabolism, excretion of the drugs. It will also make the older adult more prone to adverse drug reactions to toxic amounts of, medications building up in the bloodstream that can also, result in even psychotic manifestations. And then, of course, pharmacology. We know that older adults tend to take more, medications, and when they take more medications, and there's an increased, likelihood that there might be some drug-drug interactions, some drug disease, interactions that can also, oftentimes, unfortunately, that can be the root cause of some of the symptoms that may be manifesting. And so then this leads us to the elderly and medications, so don't be blindsided per se. So we should all be aware, as family members and even as professional, caregivers, that the more medications an individual takes, an increased likelihood that they will experience adverse reactions to medications. That really accounts for a large percentage of hospitalizations, even for older adults. And so, so when this is the case, and we're aware that, our relative is taking many different types of medications, so we want to always take that into consideration. So always let the various healthcare providers who are treating our relatives to know, what medications that they're taking, keep an up-to-date list, and then also have those medications surveyed to see, in essence, if some of the root causes of those behaviors could be from medications. So I like to always say that prior to actually using any type of, antipsychotic medication, that to look at this checklist. So first of all, we want to rule out, again, any medication side effects that could be contributing to some of those behavioral, symptoms of dementia, including the hallucinations and the delusions, underlying medical conditions, again, the social and physical environment, because we don't want to make sure that the environment is not prompting sensory overload. And of course, it's not also contributing to a sensory deprivation. So the result of some unmet needs that I mentioned previously. And then we have to take into the context of individuals' lifelong personality traits that also has to be factored into the overall assessment. And then, of course, we want to always advocate the use of non-pharmacological interventions as a frontline approach to the treatments of these symptoms. So when medications are used, we want to make sure that the symptoms are clearly identified, the target symptoms are identified, because then we need to have that as a basis or a framework to determine if the medications are really being effective in treating those symptoms. So now these are some antipsychotics that are oftentimes used with dementia-related psychosis. So we also know that antipsychotics are really, when they're used, they're considered off-label use because they haven't really been approved by the FDA for treatment of dementia-related psychosis. They historically have had a limited efficacy in treating these types of symptoms. And of course, we know that due to the black box warnings, these medications have been associated in many instances with a short-term, mortality, mainly due to strokes. So there are some common side effects that can occur, such as sedation that we're aware of. The individual will be more at risk for falls and injuries, dizziness, drops in blood pressure that can also result in falls, even confusion. And then some of the common side effects from the antipsychotic drugs can also include extrapyramidal symptoms. And those symptoms mainly include tardive dyskinesia. When taken over a long period of time, then you see the abnormal movements that will occur, with the mouth and other body extremities, and then Parkinson's type symptoms as well. So these will be some guidelines in the use of antipsychotics in persons with dementia. As I mentioned, we want to always use non-pharmacological interventions as a frontline approach, to use only, again, when the symptoms are severe, when they present a danger to self or others, or when they cause significant distress in the individual. That the risk and benefits should always be assessed by the clinician and also discussed with the patient when appropriate or feasible. Definitely the involvement of the family as well. So we should also know that antipsychotics should never be used to sedate an individual or to use as a chemical restraint. And as with most drugs in older adults, we want to use a minimum dose and then to use that for the shortest period of time. So this is just a slide that shows the black box warnings. I'm sure that some of you are aware of, but these date back to 2005. That the FDA issued these black box warnings of increased risk of death associated with the use of atypical antipsychotics. So those are the newer, or what's called the second generation antipsychotic drugs. But then in addition to those drugs, then there are also black box warnings that have been extended to the conventional. So these would be you could say the first generation antipsychotic drugs, or the older ones, that they can also result in increased risk of death when they are used in older individuals with dementia-related psychosis. So now, is that ever to say that a person, that has a dementia-related psychosis would not be, antipsychotic use would not be appropriate? Well, that's not the case. In some instances, those medications would be required, but they would have to be prescribed with caution. So these are some inappropriate treatment targets for these drugs. So we wouldn't use them just for restlessness in and of itself, for impaired memory, for wandering, for uncooperativeness. These would be considered inappropriate treatment targets. And also in terms of verbal expression or behaviors that are not representing an immediate danger or threat to that individual or to others in the environment, or for nervousness or for fidgeting. So those would be reasons why we would not want to use an antipsychotic medication. Okay, Gina, I'll stop my share.
Gina, I think you're muted too.
There we go. And let me get back to my share. All right. Can you see this?
Mm-hmm.
All right. Let me get down. Sorry, I lost my place here. All right. So are we on target?
Mm-hmm.
These are probably familiar to you because if any of you have read the 36-hour day, which is the Bible for caregivers, this is referenced regularly. And actually in many of the talks and presentations, we reference this on a regular basis. So I'm not going into a lot of detail about it. It's in your handouts, but these are the things that we want to manage if the person becomes aggressive because of the psychosis. These are things that we do first too. Restrict. We try to maintain a calm demeanor. We reassess what are the things that might be causing this. Has there been an incident? Is there physical pain? We want to reconsider. We empathize with the senior person, with the older adult. We want to rechannel, redirect the person if there's an activity. We want to reassure them, and then we want to review. Was there something there in their environment perhaps, or something going on that might have been a kickoff to this, or contributed to, the psychosis, the delusion or the hallucination becoming exacerbated. So we want to talk next about adjusting the environment, because these are some things that we can do immediately that we have easy access to. And one of the things that we want to do is we want to look at things, we want to put things, make them simple for our loved one. We want to designate places that, if their keys get lost, if their glasses get lost, we want to have spares, because that's one of the first things that can trigger somebody who might have paranoia. Somebody's stolen my keys. Somebody has taken my glasses. You've taken my glasses. So as much as we can to simplify their environment, we want to do that. We also want to consider if there's new people coming into the environment that might create confusion for them, or fear or worry. We want to, as much as possible, avoid any unnecessary changes to the home. This may be a time that I know many people are trying to use technology, but be aware that that can create some paranoia, and familiarity is the best thing to reduce paranoia. We want to review the environment for anything in the room that might cast shadows, or that makes the lights work in a certain way, or has them confusing reality. I'll tell you, just the other day, I walked into a room, I had an extra coat rack, a movable one, and I walked in, I forgot it was there, and it startled me. Those are some things that contribute or make their delusions or hallucinations that can feed into that. We want to eliminate any kind of violent or disturbing TV that can be frightening or confusing. Sometimes even just the music of a TV show, can create concern. And always it's important that we're always reviewing any kind of auditory or visual medical issues that might be going on. That's really one of the first things that we should address. And then when I did this, I realized I forgot one of the main things, and that is we have got to always make sure the environment is safe. And what I mean by this is that if we know that our loved one is having trouble with paranoia or psychosis, and they might be in the mode of protecting themselves or their family members, anything that can be dangerous, guns, knives, if they've made a comment about that, that needs to be locked up. That needs to be taken care of first. So talk about what does it look like. So I want to give you a vignette, and Dr. Spurlock and I are going to talk through this. So Dr. Spurlock, we're going to talk through this in a second. So here's the situation. Miss Emma, she's 74 years old. She lives with her daughter. She has 2 children, a son and a daughter. Her husband died 4 years ago. He had been very ill with cancer. And the couple had moved in with Miss Emma's daughter. But less than a year after her death, after the death of her husband, she was diagnosed with Alzheimer's. In the earlier years with her husband, she used to travel a lot with her husband. She traveled all over the world, very savvy traveler. And she learned that she had to be very cautious in strange cities. So she was always having her bag, always had her purse very close to her. So this habit has served her very well. But she has been increasingly anxious and fearful and more suspicious. So 3 weeks ago, Miss Emma misplaced her purse. And it's any one of us know how anxiety provoking this can be, right? I mean, when I lose my purse or even misplace it in my house, my anxiety goes up. My identification's in there, my cell phone, all of us remember that feeling. So today, she's hostile. She's accusatory of her daughter for taking her purse. She told the daughter she was always hiding her purse. So let's go ahead and let's start with Miss Emma.
Where's my purse? I know you took it and I want it back. I have my driver's license, all my money in there. You're always taking my purse.
What? What would I want with your purse? I don't have your purse.
Well, I can't find it because you stole it.
How could you imagine that I would steal your purse, Mom?
Because you're always stealing my purse and my things.
Well, don't you remember? You probably left it in your room. Isn't that where you always put it?
No, you're always stealing my things.
I am not always stealing your things, Mother. You misplaced it.
I didn't.
So you saw the not so good responses, right? Now let's try a better response. Go ahead, Miss Emma.
Where's my purse? I know you took it and I want it back. I have my driver's license and all my money in there. You're always taking my purse.
You can't find your purse and your purse with your driver's license in it?
Well, I can't find it because you stole it.
And I know that you always take such good care of your purse, Mother.
You're always stealing my purse and my things.
How about this? I'm going to help you. Let me help you look for it.
No, I want my purse.
How about you and I'm going to go in your room and I'll help you look for your purse.
Okay.
So there you did. You saw that, how it could go right, how it could go wrong, and how it could go right. And I will share with you that I talk to many caregivers, I do groups, I see people individual, and I'm not going to say that this isn't very hard to do where you're where you're tired, you're in the crisis of the moment. But I think the most important thing is to always remember that they're reacting to their fear. And the way you react, it's most important is you don't want to win this battle. It's not about winning it. It's about winning, winning the overall situation. Before we finish up here, I want to share that these are some resources that we've given you. This is excellent information here that you can find. You can find additional, some of the research that we've talked about. And this is how you can reach us. Here's my email, my phone number. Here's Dr. Spurlock with her phone number. Please feel free to contact us if you have any additional questions. So we've left, we kind of spent through, I'm not very good at time, but this is where we are, where we have some time to answer some questions. So please share. I've not checked in the email, I've not checked in the chat recently, but we have some more time for discussion. So we've got 15 minutes.
All right, let's see. I see we have a few questions in the chat. Let's see. We have a comment back for you, Gina, from Miss Kim. Let's see. We have wonderful presentation. Thanks. And then we have a question that says, is there anything wrong with giving a person with dementia an over-the-counter sleep aid like Relaxium Sleep, which is magnesium, L-tryptophan, valerian root, and a few other things that I cannot present myself.
Yeah.
Dr. Spurlock, you want to take that one?
Right. And these are, we just have to be aware that unlike medications per se, that these types of agents have not gone through any, FDA approval, process per se. So it's not to say that they would be unsafe, but I think it's always a good idea just to let the medical provider know what types of, over-the-counter remedies per se that we may be giving our relative, because in some way they could maybe be contraindicated, in the scope of other medications that might be taken. So I think it will be a good thing just to let the medical provider know.
Thank you. Another question says, my mom frequently says she wants to go home when she is home. What is the best way to answer this?
Yes, and I think, if we think about Naomi Fowle and her, validation therapy, because I would often see this in clients that I would work with at 3 o'clock in the morning in the hospital. And then they would be saying that, I want my mother, I want to go home, or relatives who are already at home. And so then we know in essence, in the past, we would just say, well, to orient them to reality, to say, well, look, don't you realize in essence that you're already at home, this is where you live. But generally, that's only going to escalate, the situation. And so we just advise more or less to try to approach that person from a feelings, perspective. First of all, to acknowledge more or less that this is, upsetting, to them, and to maybe to try to distract them, with a pleasant type of activity, or maybe just to find out more in terms of what's really prompting. So maybe the person is really, missing maybe family members who maybe lived with them in the past and, is no longer there. So, but I would just say to approach it from a feelings, perspective, and then to acknowledge that it can be distressing to them.
So Naomi Fowle, Alzheimer's Services has brought her here in the past. I've been fortunate. I've got to be with her twice. If you've ever seen her trainings, they are very real. She has a history as she was an actress. So as she talks out, as she acts out these situations with somebody, this, for example, is saying, I want to go home, she becomes very compassionate and loving. Like Dr. Spurlock says, she refers to the feelings. Tell me about your home. What are you missing? Your home, your room? Tell me about that. And so the person's allowed to express, what it is they're missing. I'll tell you, she is such a good actress. I've never been so close to somebody that when they were doing a role play, they actually drooled. I mean, that was shocking to me, but she really gets into training. So that book is called Validation Therapy by Naomi File.
Right. And if you're interested, some of her videos can also be accessed through, YouTube. If you just type in, her name, and then you'll get some of her videos to come up.
Thank you both. And I'll put Naomi File's name in the follow-up email for anybody that wants to check her out too. Okay, our next question says, how do you know when to remove guns and such without causing arguments or paranoia that someone is stealing the guns or personal possessions?
I'll tell you what I would do is I would address this early, and I would take responsibility, and I would say that I feel like I want to put this away because it's me. I'm putting this away, and to take a thing that I definitely would not let them know that it's because you're dangerous or you're forgetting things, and I don't want you around this, Dad. Say, no, I'm feeling safer if the guns are put away, Dad. That way, it's about you. And then certainly, one of the things we know that hopefully with time, these things, because it is a progressive illness, that stops, that will slow down, and that will go away. In our culture, in Louisiana, hunting, this is a tough one, and the families really struggle with this. But to me, it's too important to not. This is one where you certainly have to kind of take the hit. It's going to hurt. They will be angry, but the important thing is that everybody be safe. Did you want to say something, Dr. Spurlock?
No, I was going to say, when you say to take the hit, but we want to take that earlier, more or less, in terms of making that decision just to make the overall home safe, not only with guns, but it could be other situations that will make the home unsafe too, especially if you're noticing that they're having difficulty remembering to turn off the stove, burners, to leave doors unlocked. So it's an overall home safety issue.
I think the difficulty is thinking that there's going to be an answer to make the disruption or the anger or the hostility go away completely. Right. And unfortunately, there are situations where what we can do is just minimize it sometimes, but these are not going to be, foolproof, and you're not going to get out of the situation sometimes without some feelings of anger, resentment, unfortunately.
Yeah, sometimes car keys, surface as an issue too, and that's another safety.
Yeah.
Okay, thank you both. We have a few comments that kind of goes along with some of the things y'all have shared. We have someone that said, I deal with the purse situation on a daily and can attest that the helpful route is the way to go. Anything else will make them upset. We also have another comment that says, my sister is in a nursing home, 74 years old with dementia. A few months ago, her dementia was stopped abruptly. This resulted in agitation and aggression, admission to a neuropsych facility. And then this is from Ms. Sheila Ross. She says, wonderful presentation. Great to see you, my friends. It was all the same comment.
Oh, wow. Sheila Ross. We miss Sheila Ross.
Yes, we
do. One of the most fabulous. I think I see her. Is that you?
There she is.
Sheila, we miss you.
We do.
Sheila is a part of the history
fabric.
Like Dr. Spurlock, of working with older adults in our community. She's been a mentor to many nurses as well.
Yes.
And we have another comment that says, I found it helpful to have a couple of items that brought familiarity to Mom. Her favorite rocker, photos of grandkids of her best friend, and Dad, his guitar, photos of family in their rooms at the nursing home facilities / memory care units.
Yes, most
Excellent.
definitely. Yeah, we would always, encourage that when possible to personalize it, with, belongings and memorable things from the person's home environment. And then also to realize too, that oftentimes some of these, psychotic symptoms per se, or the behavioral and psychological symptoms of dementia, is that they can really become heightened with transitions. especially in terms of transitions in treatment, like areas per se, if the person goes from home, to an acute care or a hospital, and then the person is maybe transitioned, to a nursing home or assisted living. So all of those transitional points per se can really disrupt a person's functioning, their mentation and, cognition, and then can result or amplify some of these symptoms. So those are things always to be mindful of, and to try to, taper those environments to be as personable as possible.
Thank you. And Ms. Sheila shared that Dr. Spurlock gave her first nursing job. We have another question that says, are there any go-to phrases you suggest to use to redirect/calm down an upset loved one?
Well, one of the things is to acknowledge their feelings. If they're saying, I'm really mad at you about this, to say you're angry about not having your, whatever, you're acknowledge it, repeat it for them. If you have a trouble with a go-to, think of repeating what they said, because that will know that you're hearing them. That's one of the most important things.
Mm-hmm. And then I might add to that, in terms of we refer to as person-centered, types of approaches. So it's always, of course, good to know something about the individual. Mostly family members know this, but even when a person with dementia is treated in a treatment facility, per se, to know something about that individual's background in terms of maybe what were some of their hobbies that they have, maybe their previous, occupations that they've had, if they maybe love gardening, to fish. And sometimes these can be used as incorporated into distractions, more or less, but then they become more meaningful, for the individual, because they can relate, better from prior history and experience.
Great. Thank you both. We also have lots of really lovely comments in the chat that I've saved, and I'll be sure to share with you two after the presentation. But that concludes all the questions that we have. Thank you so much, Dr. Spurlock and Gina. This is a fantastic presentation. Such an amazing opportunity to have insight from both of you to learn from. So thank you so much for taking the time out of your day, and both, I know your busy schedules, to be able to do this. And we look forward to having you guys join us again in the future.
Thank you. Thank you for inviting me, and thank you for me being allowed to work with Dr. Spurlock. I always enjoy it.
Yes, and same here. And then just to thank all of our family members, who have attended to, and as Gina mentioned, it's an ever learning, growing process, and we always learn, from our family caregivers as well.
Absolutely. Thank you both. And thank you so much to everyone who joined us today. Just another reminder, keep an eye out for those emails for November. We'll have lots of fun stuff coming up. So thank y'all so much, and hope everybody has a good rest of your day.
Thank you.